Namaste. Good evening. Indian Medical Association Sulla branch is organizing 3rd CME. I welcome one and all. Ophthalmology Revisited is the topic of discussion today. I request Dr. Avikant sir to do the IMA prayer.
Good evening, everyone. ಭಾರತ್ ಕೆ ವೈದ್ಯಕೀಯ ಸಂಘದ ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವ ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವನ್ನು ವಂದಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವೇ ನಮಗೆ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ ಮತ್ತು ಅದರ ಪದವೇ ನಮ್ಮ ಪದವು. ಮಾನ್ಯತೆ ಪಡೆದಿರುವ ರಾಷ್ಟ್ರ ಸಂಸ್ಥೆಯ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ನಮ್ಮ ರಾಜನಿಷ್ಠೆಯ ಶಪಥ ಮಾಡುತ್ತಿದ್ದೇವೆ. ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜದ ಉನ್ನತಿ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು ಎವ್ರಿವನ್.
Thank you, sir. Today we have 3 topics for discussion: quest for an ideal cataract surgery, diabetes and eye a proximate type, and Odyssey of refractive surgeries. Today the first topic is quest for an ideal cataract surgery. Will be discussed by Dr. Shivaram Kevi, who is the medical director and senior phaco surgeon in Ganesh Nethralaya, Sirsi. I request Dr. Amit Kumar to introduce our guest of honor today. Please, Dr. Amit Kumar.
Good evening, everyone. IMA President Sulla and Secretary and all IMA office bearers and all IMA members and today's chief guest. It's a great pleasure to introduce Dr. Shiram Kevi, who is a phaco-refractive surgeon with more than 25 years of experience. He is founder, medical director of Ganesh Nethralaya Super Specialty Hospital. He is passionate about operation theatre planning and management. He was honored by IMA State Branch for Life Achievement on Doctor's Day for Best in Community Services. Rotary International awarded him for his professional excellence. Under his leadership, Sirsi IMA bagged Best Branch Award both as Secretary in 2001, 2002 and as President 2012 and 2013. Thank you.
To add upon with the introduction to Dr. Shivaram sir, he is not only the passionate doctor, he is a passionate, is interested in literature and giving so many chances to the literature person, and is arranging so many programs. He has a Nayana Nayana hall where he is arranging programs every now and then. So I welcome Dr. Shivaram sir to give the lecture on quest for an ideal cataract surgery. Please, sir.
At the outset, I thank Sulla branch of IMA for inviting our institution and especially me for this wonderful CME, and special thanks to...
Recording in progress.
I just started the screens.
Yes, sir.
Can you see now?
Yeah.
The slide is not moving, madam.
It's not moved.
Now, okay?
Yes, sir. Yes.
So now I'll be discussing this topic of quest for an ideal cataract surgery. We are all blessed with this beautiful vision to see the world. But globally, almost 37 million people are blind, and out of which 60% of blindness is due to cataract and refractive error. I don't want to go in detail about cataract, as most of you know that The cataract is the clouding of the normal clear lens within our eye. Just like in any camera, we have a lens which is crystal clear or transparent. Whenever the transparency of the lens is reduced or it becomes opaque, that's called cataract. As we know, our clear lens function is to refract the light into the retina and focus over the retina so that we can see the clear vision. Whenever it becomes cloudy or opaque, and it prevents the light from focusing sharply onto the retina. See, there are so many varieties of cataract depending upon its maturity, like mature, immature, or hypermature. That's the totality of the opacification, or the place where it is started, like posterior polar, posterior subcapsular, nuclear, like that. Because as we know, the lens has got three parts, like nucleus, cortex, as well as capsular. So which place that cataract is started in the initial part, that is also classified. And what are the symptoms of cataract? See, most often it is a painless blurring of vision, and most commonly it's a glaring of light and light sensitivity whenever we see the bright light, just like in the second photograph you can see, and poor night vision and double vision, or sometimes diplopia or triplopia in one eye. And in the initial period, whenever there is a nuclear cataract, they need brighter light for reading, and fading of yellowing of colors, of the color change. Those who are very sensitive, they can appreciate in the initial stages. These are few symptoms of the cataract. Let's know when we are supposed to do cataract surgery. It's not that presence of cataract needs a cataract surgery. Whenever it interferes with our day-to-day activities, like performing our profession or job, or driving difficulty, or reading or watching TV, whatever we do our routine activities, for that particular person, it is interfering with his activity, then we need to undertake the surgery. And if it is left behind, if it becomes mature or hypermature and neglected, sometimes it can complicate itself into secondary glaucoma. It's like phacolytic or phacomorphic glaucoma. Then the management becomes little more difficult. What's the ideal cataract surgery? See, whenever we think of ideal cataract surgery, what we expect is an early visual recovery, minimum pain or discomfort, and quicker to heal, and with predictable results and early routine activities, resuming to the routine activities as early as possible. And it should be safe, like minimum chance of infection or any complications. And there should not be any post-operative glare, and there's no need or least dependency on spectacles in the post-op period. This is the ideal one. When we come to the varieties or the way the cataract surgery was developed from last centuries, and see, initially in the Sushruta time, it started with couching. It is just by a needle put in the limbus part, and the hypermature cataract is just pushed into the vitreous cavity. That's called couching. And next came the intracapsular cataract extraction. That is the removing the whole nucleus along with the capsule outside, and then extracapsular cataract extraction. That is leaving behind the posterior capsule behind and removing only the nucleus as well as the cortical part. And next was the small incision cataract. In the extracapsular cataract extraction, we need to have around 10 to 12 millimeters of incision, and it is closed with 4 to 6 sutures. And next came the small incision cataract surgery, wherein the scleral tunnel, sclerocorneal tunnel is made. It's a self-sealing incision the incision is lesser, like 5 to 6 millimeters. It may or may not need the sutures. And then came the phacoemulsification. Right now, that is the standard, gold standard treatment is phacoemulsification. And then recently, laser cataract surgery is also being developed. And I'm fortunate in my 3 decades of experience in the ophthalmology. I'm fortunate to come from intracapsular extraction to through extracapsular, through small incision and phaco. And I've seen all the changes taken place in last 2 to 3 decades. And it's really happy to be there with all the changes. And what advancements are there have taken place all these 2 to 3 decades. It's a preoperative advancement is in the optical biometry. Biometry is calculation of intraocular IOL's power of the intraocular lens, and OCT, B-scan, pentacam, specular microscope. All these equipments have helped us for predictability of the results of the cataract surgery in various ways. Let's see later. And during the operative equipments, as a modular operation theater, which minimizes the infection, and microsurgical instruments. There is a lot of advancements in the surgical instrumentations. And then microscope, excellent microscope with coaxial illumination have helped us to do the best of the surgeries. And modern phacoemulsification machines with IOP control, vitrectomy whenever there are certain complications like postcapsular ruptures. And of course, IOL technology has also improved over a period of especially last 1 decade, and it's an excellent improvements are there. Almost near ideal surgeries we can undertake. As I said, phacoemulsification with foldable IOL implantation is the gold standard for the surgery of the cataract right now. See, in that, what we do under the microscope with the help of the phaco machine, initially we open up the anterior capsule. We make CCC, that's a curvilinear circular capsular axis, how it is seen in this picture. And then hydrodissection, separation of cortex and the nucleus is made. And then the nucleus is emulsified in a very small incision up to 2 to 2.5 millimeters, and it is cut into pieces and sucked out with the help of this machine. And then after clearing all the cortex and all, the foldable intraocular lens is implanted within that same incision. Let's see a small video. It's an animated video. This is the incision made, and the viscoelastic to protect the endothelium of the cornea is put. With the cystotome or a bent needle, anterior capsule is removed. And then after hydrodissection, this is the probe of phaco. The whole nucleus part, almost it will be 8 to 10 millimeters. It is removed in bits and pieces and sucked out. This is the intraocular lens. Foldable lens is inserted, just like a spring. It will implanted in the bag implantation. That's the most ideal place. It's a natural place. I said phaco is the standard procedure right now. What are the advantages of phacoemulsification? It is quicker visual recovery because it is 2 millimeters or less, and it's less. It doesn't induce much astigmatism. Astigmatism is the cylindrical power comes post-operatively due to the change in the curvature of the cornea, and it reduces the visits, post-op visit to the doctors, and complications are also much less because it is a closed system. And most of the surgeries are done under topical anesthesia only by putting the paracaine drops or jelly. And sometimes, if it is very hard cataract or pupil is not dilating or hard of hearing or uncooperative patient, we may need to do under peribulbar or retrobulbar or subtenance injection. What are the challenges we face in the modern cataract surgery? See, especially about refractive predictability. Expectation of the patient is that we should not need, or the dependency on spectacles should be as less as possible. The predictability of refractive error is also a very important challenge. And what is the visual potential, especially in a mature cataract or with the diabetes with retinal diseases? So what is the outcome of what is the visual expectation after the cataract is also important. And sometimes, rarely, some complications like posterior capsular rupture or the nucleus drop and such complications can happen. How to handle or manage that? And most important is the prevention of infection. Almost endophthalmitis or infection is the dead end most of the time. And recently, with the advent of vitrectomy and vitreoretinal surgeons' help, we can even salvage the vision. But still, every ophthalmologist is scared of this post-operative infection. And updating technology and knowledge, because as an ophthalmologist, we are always dependent on many of these equipments and technology, which getting outdated every now and then, 3 to 5 years. We need to update. We need to change the machineries. And this is also a big challenge and learn these things. And coming to the preoperative biometry. Biometry is, as I said, it is the calculation of the intraocular lens power. See, earlier we used to use ultrasonic biometry, and now also many of the centers use this. See, it's a little cheaper one and easy to maintain. But the thing is, the predictability, the accuracy is around 85 to 90% only. The recent advancement is optical biometry. It uses the light for calculation, and optical biometry is almost 98 to 99% accuracy, especially when we plan for the premium IOLs like toric lenses, multifocal lenses. This really helps us. And D-scan is an ultrasonic scanning vision, and wherein whenever there is a mature cataract, we can know the retinal anatomical status, whether it is normal or vitreous hemorrhage or retinal detachment, any pathology is there. And next is the OCT scan. It's a really handy. OCT scan is the one which is just like a CT scan or the MRI. All the 10 layers of retina is scanned and pictured like this, and wherein we'll know the exact anatomy or any diseases in the macula, which is a very important part of the retina. And then pentacam, it is for corneal health and corneal curvatures, especially for toric lenses. And sometimes in diabetic patients, we may need fundus camera and fluorescein angiography. And as I said, modern and safe operation theater and its maintenance is very important for prevention of the infection, like class B autoclave and strict protocols for instrument maintenance, using disposables as much as possible. All these are very important for preventing infection. And sometimes some complications can happen, like post-operatively, posterior capsule opacity, we need YAG laser capsulotomy. And if there is posterior capsule rupture or nucleus stop, we need vitrectomy. These are some of the equipments we need for managing the complications. And lastly, coming to the intraocular lens technology, there are so many wide range of intraocular lenses are in the market. And modern cataract surgery is more of a refractive surgery, not only the removal of the lens and also reducing the dependency on spectacles. So there are mainly, depending upon the functions, many varieties of lenses comes. The most commonly used is monofocal lenses. These monofocal lenses correct the distance only. But for reading or intermediate vision, we may need glasses once again. And the bifocal lenses comes for both the distance and near. And trifocals for distance, near, and intermediate also. Intermediate is when we, like now we are using the laptop or driving, we need to see the dashboard. And while kitchen in arm length distance, all these things are also clear with these bifocals and trifocals. These are all called multifocal lenses. The disadvantages of multifocal lenses in the initially is the problem of driving. It's a glaring will be more in that. And recently extended depth focus lenses also comes with better intermediate and distance vision, which has got less glaring. And the very important another type of lens is toric lens. This is very important for correction of astigmatism or cylindrical power. I'll tell you in detail in the next slide what exactly it is. And now toric trifocals and toric extended depth focus lenses also come. In very special situations, sometimes we may need to use scleral fixated lenses whenever there is not much of support, posterior capsule support. And sometimes iris claw lenses, three-piece lenses, aniridia lenses. These are some of the special lenses used in special situations. And in the technology now, aspheric lens technology has come with the image quality is much better and contrast sensitivity is also much better in these aspheric lenses. And this is a picture of the monofocal lenses, toric lens, and multifocal lens. As I said, in the monofocal lenses, only distance vision will be much clearer, and for near, it's not much clear, and we may need to use glasses for near work. And coming to the multifocal lens, as I said, though the distance and near are clearer, but the glaring, and especially at night time, those who drive is a little challenge. But recent advances of trifocal lenses, it is also lesser compared to the earlier period multifocal lenses. And this is how the multifocal lenses are made. This is because this is the reason the glaring will be there, because many ranges the lenses, the parts of the IOL are late cut in such a way that different areas focuses on the different distances. And this is a specialized toric lens. Whenever we have astigmatism of cylindrical power of more than 1 or 1.5, it is a significant astigmatism. Even when we use the monofocal lenses, they need a spectacle for distance also. To avoid that, toric intraocular lenses are used. And for that, accurate biometry and calculation is very important, pre-operative calculation. And then we need to mark the axis on the cornea pre-operatively just before surgery once in the sitting posture and like this. And then on the table, we need to put the lens in the bag and then align it in the axis wherever it is calculated by computer. We need to align this. Even the intraocular lenses will have mark like this, and we need to align in the same direction so that the cylindrical power is negated in that. The recent advances, which is in the O, is FLACS or femto laser assisted phaco surgery. it is called. In that, few of the steps of phaco surgery, like making an incision on the cornea and perfect capsular access and breaking of the nucleus into different uh, in multiple fragments. These 2-3 steps are done with the help of femtolaser, so that some of the complications related to these steps are uh, avoided. But right now it is available in few centers and it's a little bit costlier. And this is how the femtolaser is fragmentation is done. With the modern cataract surgery, what should be our expectation? Most cataract surgical surgeries are performed without complications, and result is immediate improvement in the vision in most of the patients, and only 0.1% chance of reduced vision due to other reasons. And we need to apply eye drops for 4 to 6 weeks for reducing inflammation, and may need spectacles for clearest near vision following surgery. Will the cataract come back? Absolutely no, because we have removed the lens, but sometimes as we have left behind the posterior capsule, and few people, it can become thickened. That's called posterior capsular opacification, of also called as after cataract. We may need YAG laser capsulotomy in such cases. This is more common in younger people whenever we do surgery, or also in the lower end hydrophilic intraocular lenses. Also, it is more common. Some of the myths and facts of cataract. There is no necessary to wait till the maturity. All decrease in vision need not be due to cataract. Sometimes many people come saying that we have cataract just because of age. Sometimes glaucoma, diabetic retinopathy, macular disease, so many other reasons for decreased vision in the elderly. And with the modern advancement in surgical microscope, micro-incision phaco technology, and precision optical biometry, and advancement in IOL technology, and of course, with the experienced, well-trained surgeon, cataract surgery has become much safe with the least complications and very few complications we can expect. Even though surgery is uneventful in some of the conditions, we may not be able to get best of the vision due to some retinal problems also. To conclude, surgery is the only treatment for the cataract. Accurate biometry and proper pre-operative assessment is the key for success. And modern daycare micro-incision cataract surgery under topical anesthesia is the gold standard. Early visual rehabilitation is the key for phaco surgery. And there are range of IOLs available depending upon the profession or requirement of the patient. Femtosecond cataract surgery is being improved. And for success, for the happy patient and happy surgeon, refractive history of the patient, and understanding the needs and work profile and lifestyle of the patient, and proper guidance and counseling, all these are extremely important. And cataract surgery is a teamwork. Surgeon is the captain, but for the success, optometrists, biometrists, counselors, OT personnel, technicians, assistants, housekeeping staff, store managers, records keeping, and back office management staff, equipment maintenance engineers or technical staff, microbiologists, everybody is important. They play their role. Then only the surgery becomes most successful. Thank you. Thank you so much.
Thank you, sir. Such a elaborated quest for an ideal cataract surgery. And it was a wonderful lecture. And you have a very good team with the vision of giving a vision to the people. I congratulate you on behalf of IMA SULLA, and the questions we will take in the after the two topics. Now we will move on to
Thank you.
the common problem of today, the diabetes and eye, a proximate eye, by Dr. Manjunath B A, vitreoretinal consultant, Dr. Soumya, our treasurer, and ENT surgeon working in CHC Sulla, will be introducing Dr. Manjunath B A. Please, Soumya.
Thank you, ma'am. Good evening, all. It's my great pleasure to introduce Dr. Manjunath B A. He did his MBBS from KIMS Hubli, and he did his DOMS DNB from Bangalore, NBE from New Delhi, fellowship in Refractive Surgery done from Bangalore, and FRCs from Glasgow. Worked as a consultant at Joshi High Hospital, Hubli, was consultant at Karthik Netralaya, Bangalore, presently working as a vitreoretinal consultant at Ganesh Netralaya, Sirsi. He is a life member of IMA Sirsi. He is a life member of Karnataka Ophthalmic Society. He is a life member of All India Ophthalmic Society. He is a life member of Vitreoretinal Society India. Presented and actively participated in various state and national conferences. Is a principal investigator in various drug trials. Has several publications in national and international ophthalmology journals. Over to you, sir.
Thank you, Dr. Soumya. And to add upon that, Dr. Manjunath is a poet and a writer. His write-up has come this time in Vaidya Sampada. I welcome you, sir.
Thank you, madam. First of all, I'd like to thank for IMA SULLA and especially Veena madam, who is a very active and dynamic president, which I recently have come across in IMA, for giving us an opportunity. Allow me to share my screen.
Yes, sir. Madam.
Is it seen?
It's seen, but I think it's not from the starting.
Not from starting. Yeah, 1 second. Okay.
Yeah.
Yeah. Good evening, everyone. As you all know, diabetes is one of the common diseases which you come across. I'm not going in detail about how diabetes affects the eye. Just we'll have a bird's view about diabetes and its implication on the eye. So these are the few interesting facts which we come across. Like, as you know, recently the incidence and the prevalence of diabetes has been increasing in the low and middle income countries rather than highly developed countries. So diabetes is one of the major cause for blindness, your kidney disease, heart attack, stroke, and lower limb amputation. It is estimated by 2030 there will be 80 million patients who will be affected by diabetes. So diabetes, as you know, it's turned out to be an economic pandemic. Why? Because it mainly affects the working class group, mainly like 40 to 60 age or 20 to 60 age. These are the age group which are mainly affected by diabetes. That's why it's considered to be an economic pandemic. You know that India is considered as a diabetic capital of the world. And by 2025, it is estimated that 6% of the adults will be affected by diabetes. So what are the responsible factors for diabetes? Is mainly hereditary, genetic, a change in lifestyle, urbanization, or increased intake of carbs, increased life expectancy, as well as stress. So you know that diabetes is called as a king of disease, not to forget the 4 pathies like neuropathy, nephropathy, retinopathy, and cardiopathy. And there is a strong correlation exists between nephropathy and retinopathy. So whenever you see a patient having some amount of diseases associated with kidneys, you should always suspect the patient having some amount of retinopathy. So what are the organs which are affected in diabetes due to eye? Almost all the organs are affected, starting from your eyelids to retina. Just to brush up, If it affects the infection of the eyelid gland, this is known as TIE, or if the non-inflammatory condition known as chalazion, or whenever there is an infection of the lid margins, it is known as blepharitis, or there can be dry eye. Some of the extraocular involvement in the form of orbital cellulitis, or they can see the fungal infection of the eye in form of orbital mucormycosis. Other common manifestation which you see are, sorry, there's some, is like there can be a frequent change of glasses, or there can be cloudiness in the cataracts, where you can see in early age group. So it is mainly because of the metabolic disturbances which occur across the eye. So another thing what you can see is the non-healing corneal ulcer. Whenever you see the non-healing corneal ulcer, you should suspect a patient having some amount of diabetes. So another thing is there can be a paralysis of eyeball. As you all know, eyeball is supplied by all these the third, fourth, and sixth cranial nerves. All the cranial nerves can be affected by means of diabetes. It is known as diabetic neuropathy, is one of the common long-term complications which you see in type 2 diabetes. One more thing is glaucoma, especially neovascular glaucomas are quite common in patients who are having diabetes. You know that the prevalence of glaucoma in India ranges from 2.6 to 4.1%. Again, the vein occlusions are quite common in patients with diabetes. Like you can have a central retinal vein occlusion, or you can have a branch retinal vein occlusion, or you can have arterial occlusions in the form of central retinal artery occlusion or a branch retinal artery occlusions. One more thing is optic neuropathy. There are mainly two forms which you can see. There can be associated with papillitis, or there can be a non-arthritic AIONs. That's quite common in patients with diabetes. So this is how the normal retina looks. This is the optic nerve. These are the vessels. This is the macula. So coming to retinopathy per se, which is one of the most common thing which you see in patients with diabetes. So what is retinopathy or diabetic retinopathy? It refers to any changes occur in a fundus as a result of microangiopathy is known as diabetic retinopathy. So who are at risk of developing diabetic retinopathy? You know that Type 1, which constitutes 15% of all the diabetes, they were likely to develop more severe eye complication. And type 2, which constitutes 85% of the patients of diabetes, they make up the majority of clinical cases. So what are the risk factors of diabetic retinopathy? Mainly the duration of diabetes is very important. So like longer the duration, the more chances of developing diabetic retinopathy. So there can be associated hypertension, hyperlipidemia, renal diseases, pregnancy, and cataract surgery. So as I said, the duration is very important. It has been found that longer the duration, there are high chance of having some amount of diabetic retinopathy. So after 20 years, it has been found that like 100% of the type 1 diabetes will have some amount of diabetic retinopathy, and 60% of the type 2 diabetes have some amount of diabetic retinopathy. So when do we suspect to have a retinopathy? So whenever the duration of diabetes is more than 5 years, when uncontrolled diabetes, associated anemia, associated hypertension, hyperlipidemia, or nephropathy. In all these cases, you need to suspect to have retinopathy. Easy to remember, like A, B, and C. So this is the Etds classification which we routinely follow, based on mainly on the severity of the disease, and based on the proliferation they have divided, like mild, moderate, severe, very severe, and based on the proliferation, like whether there is a neovascularization of disc, or whether there is a vitreous hemorrhage or any retinal detachment. So just having a brief look at what are the stages. In a mild Npdr, you can have these microaneurysms, these are dot hemorrhages and hard exudates. So why it need to be evaluated? It has been found like there are 15% risk of severe visual loss in 5 years. Severe visual loss, if there is a loss of 30 letters, that means the 6th line loss in ETDRS chart is known as severe vision loss. So you need to follow it up for all the cases who have some amount of diabetic retinopathy. So next is moderate NPDR. There will be increase in hemorrhages, along with you will have a cotton wool spots. Cotton wool spots are nothing but the nerve infarcts. So in this, you see that there is 33% risk of developing severe vision loss at the end of 5 years. So coming to severe Npdr, along with other changes, you will have these venous changes and IRMAs. IRMAs are nothing but intraretinal microvascular abnormalities. So in this, they have found that 65% risk of having severe vision loss at the end of 5 years. So proliferative retinopathy, in this you will have these tuft of vessels which are seen along the disc, or you can see along the elsewhere. This is known as neovascularization elsewhere. So these vessels are very fragile, they tend to bleed. So these are called a pre-retinal hemorrhages. In this, they have found 75% risk of having a severe vision loss at the end of 5 years. So word about diabetic macular edema. What is diabetic macular edema? As per the definition, it's the accumulation of excess fluid in the extracellular space within the retina in the macular area. Typically in the, it's called the open, like inner nuclear and outer plexiform layers. This is how the OCT image of the macular edema looks. These hollow places are known as the accumulation of fluid, and this detachment is known as a neurosensory detachment. This indicates there is some amount of systemic uncontrol or systemic uncontrol of the diabetes. This is the angiographic picture which showing the leakage in the macular area. So what are the symptoms you can expect in patients with maculopathy? So there can be a gradual loss of fine vision, especially the reading will be affected. So this diabetic maculopathy can be seen in all stages. It can be associated with mild Npdr, moderate Npdr, or they can be associated with PDR, with maculopathies. So as I told, there is a strong correlation between the diabetic foot as well as the nephropathy. So whenever you see any patient having some amount of diabetic foot, or whenever you come across a patient having nephropathy, you should always screen them for diabetic macular edema or diabetic retinopathy changes. So what are the symptoms you get in case of sudden onset of bleeding, or like there can be sudden painless loss of vision, and there can be sudden onset of black spots or floaters or cobwebs. These are the symptoms which you come across whenever there is a bleeding. So this is a summary of stages and how the progression occurs. So coming to diagnosis, how do you diagnose the patient having diabetic retinopathy? Not only with visual acuity. The most important thing is you need to have a dilated eye examination. Suppose if you have private practitioners nowadays, you have come up with all these non-mydriatic fundus cameras, which you can use it for screening. In severe cases, you can use fluorescein angiography whenever you have a doubt about PDR or OCT. It's mainly is a non-invasive, non-contact tonometers which are available. It helps basically in staging the macular edema. Okay, coming to management, the main goal of treatment of diabetic retinopathy is to prevent the complication that can lead to vision loss. So treatment should include both your ocular therapy as well as systemic medical interventions in the form of control of diabetes by using proper drugs, diet, exercises, and these VEGF inhibitors, and I'll come to it later. So how do you approach the patient with diabetic retinopathy? Mainly to prevent the progression. You have to prevent the progression of diabetic maculopathy as well as prevent the progression of proliferative diabetic retinopathy by means of medical management. So one more thing, you have to prevent the vision loss due to maculopathy or sequelae of PDR by means of laser, intravitreal injection, or by means of any adjunctive medical therapy. So whenever there is a vitreous hemorrhage associated with vision loss, the main mode of treatment is by surgical intervention. So what are the strategies you apply? So mainly is you have to diagnose early so that you can grade the disease and you can treat it as early as possible. There should be a proper adequate treatment, and you should have a customized treatment strategies so that you have a better outcome. And most important thing is regular follow-up. So the laser is one of the most important components. This is the laser what we use. It's a integrated 532 nanometer multi-spot laser which we use. This is how the freshly lasered retina looks. This is a single spot laser. So coming to macular edema treatment, the main mode of treatment of macular edema nowadays is pharmacotherapy. These are the various anti-VEGF medications which are available. Anti-VEGF is vascular endothelial growth factor inhibitors, mainly the bevacizumab, ranibizumab, and the aflibercept, and of late we are using brolucizumab. And even some sustained release steroids are also available in the form of dexamethasone implants. So in spite of all these treatments, sometimes some patient may progress to advanced stages, or we may get the patient with all these stages, like there can be a subhyaloid hemorrhage, or there can be a vitreous hemorrhage, there can be a very advanced diabetic eye disease, like there can be a tractional membranes over the retina. Even in these stages also, we can salvage the retina because of the availability of advanced machines. Like this known as micro incision vitrectomy surgery. It's known as MIVS, is what we are using nowadays. Basically, nothing but a high cut rate machines which are using with a small needle shaped trocar cannulas. The advantage of these small gauge instruments is like the incision size is very less, and the majority of them are sutureless, and the healing time is very less. So these small gauge instruments have certainly made the vitreous surgery more efficient and comfortable and very safe. Especially these like 23 gauge, 25 gauge, and of late we are using the 27 gauge trocar cannula system. So this is the overview of treatment, what we followed us. Whenever you have a PDRs, you can either treat with a laser, or if fails, you can consider for surgery. In macular edema, the main modality of treatment is intraocular injections, or you can add up with a focal or macular laser. So the most important thing is follow-up. So whenever you see the patient with the diabetes, after the dilating exam, you will come to know what is the stage of the disease. So whenever there is no diabetic retinopathy, you can follow them up yearly. Whenever they're depending upon the stage, mild Npdr, you can call them for follow-up after the 9 to 12 months. With a moderate Npdr, you can have a 6-monthly follow-up. In the severe Npdr, you should call them for 3-monthly follow-up. So whenever there is a proliferative diabetic retinopathy or macular edema, you should do my immediate treatment. So just to summarize, diabetic retinopathy occurs in almost 100% of the patients with diabetes for more than 15 years of duration. Diabetes can reduce the vision by affecting various parts of the eye. Diabetic retinopathy are asymptomatic even when severe. Diabetic retinopathies are amenable to treatment even in asymptomatic stages. Laser can stabilize the diabetic retinopathy and prevent the severe vision loss. So nowadays, even vitreous surgery offers some amount of hope even in advanced stages. So final thoughts, like prevention of diabetic blindness requires the active cooperation from all the medical fraternity, who need to refer the patients on time before development of any significant visual loss. Thank you.
Thank you, sir. Thank you giving for overview of diabetes and how it affects the eye from the eyelid to the retina. Yeah. Thank you. And the importance of control of diabetes is very important, as we all know. So it requires the support from the family, doctors, and all physicians and all faculties of eye. Thank you. And we'll take the questions after the last lecture. Next topic is an Odyssey of Refractive Surgery by Dr. Viswanath, Ankod, Cornea and Phaco Refractive Surgeon, Ganesh Nethralaya Shirsi. Dr. Viswanath will be introduced by our Dr. Geeta Duppa, HOD of Obstetrics and Gynecology and WDW Chairperson. Please, Geeta, madam. Madam, unmute Markoni.
Good evening, all. After the first two excellent talks, we come to the third talk of today, an Odyssey of Refractive Surgeries by Dr. Viswanath Ankod. So Dr. Viswanath is a cornea, phaco and refractive surgeon presently working at Ganesh Nethralaya Super Specialty Eye Hospital, Shirsi. He has done his MBBS from MR Medical College, Gulbarga, and MS Ophthalmology from MKCJ Medical College, Behrampur, Orissa. He pursued his fellowship in cornea and refractive surgery from Arvind Eye Institute, Coimbatore, and he has work experience from the same institute, also from Agarwal Eye Institute, Chennai and Erode. He is currently in charge of Lions Eye Bank, Shirsi, a life member of Karnataka Ophthalmology Society, All India Ophthalmological Society, Cornea Society of India, IMA Shirsi, and active member of Lions Club, Sirsi. He has given several talks at state and local ophthalmology conferences and also at various public forums. He has conducted an instruction course at Karnataka State Conference in 2019. His areas of expertise are all kinds of keratoplasty surgeries, especially lamellar keratoplasties, refractive surgery, cataract surgeries, scleral fixated IOLs, and all kind of anterior segment surgeries. So over to you, Dr. Viswanath Ankad, for your talk on an Odyssey of refractive surgeries. Thank you.
Thank you, Geeta madam. Please, you can start your talk, sir. Vishwanath sir.
Yes, ma'am. Thank you. My slides are visible, ma'am?
Yeah.
Yes, it's visible. Yeah.
Full screen agilla.
Okay.
Yes, I.
Very good evening, all. Thank you, ma'am, for the kind introduction. And I also thank IMA SULLA for giving me this opportunity for today's webinar. So to start my topic, an Odyssey of refractive surgeries. Refractive surgeries are also known as cosmetic eye surgeries. Means these surgeries done for the patients who are having refractive error, that is spectacle power, so that these patients will see clearly without the aid of spectacles or contact lens within short period of time. Hence, these surgeries have become much more popularized in ophthalmology. So let's see in detail regarding these surgeries. Before that, as we know, our eye behaves like a perfect optical system. We see the things object with the process of refraction. That means whenever we see any object or a person, the rays of light get refracted through cornea and the crystalline lens, and its clear image is focused on the central part of the retina. Hence, we perceive the perception of vision we will get to know. So any errors in this process of refraction that leads to various refractive error, that is different types of spectacle powers, that is myopia, hypermetropia, and astigmatism and presbyopia. I will not go into detail of this error. The main treatment options for all these kinds of errors, commonly we prescribe spectacles because they are easily available and low cost maintenance devices. But the only disadvantage of these devices is whenever the person is interested in a sport activities, or if he is interested in military, air force, or in pilot recruitment and all, it is a restricted use of these spectacles. And also in the patients who are having very high power, high myopes or high hyperop, they have a limited field of visual field. Their vision is limited, visual field is limited, whatever they see through the spectacle frame. Hence, in these cases, the contact lenses are the better option for them. They are cosmetically much more better, and their field of vision is much wider and as equally to normal vision. But they have the limitation for the contact lens is they have a very strict wearing schedule, and also they require proper hygienic maintenance, or else they will lead to infection on the cornea and various ocular surface disorder. And also in the military and other similar kind of profession, this use of contact lens is prohibited. In these cases, the best treatment is the refractive surgery. It's a permanent visual rehabilitation for these patients. So let's see detail regarding refractive surgery. These can be a cornea-based treatment or intraocular-based treatment, or they can be combined. The main principle of these cornea-based treatment is to change the curvature of the central corneal curvature, so that because the central 3 to 4 millimeter of the cornea is a very vital for our normal vision. So in cornea-based treatment, it can be an incision-based treatment, like in radial keratotomy, which was used to perform 25 to 30 years back. It was the main refractive surgery. Here, multiple radial cuts are made in the peripheral cornea around the central optic zone, so that it will steepens the peripheral cornea and flattens the central cornea. It is mainly done for the myopes. So the number of cuts are depends on the amount of refractive error the individual has, like 4 cut, 8 cut, and 16 cuts. But the thing was, it has got a lot many complications, and also many refractive surprises. This technique was almost it is abandoned nowadays. So next cornea-based treatment is Intax. That is nothing but insertion of intracorneal ring segment, means semicircular PMMA rings, polymethyl methacrylate rings are placed intrastromally in the paracentral part of the corneal stroma. Hence, it stretches the central cornea, means it flattens the central cornea, and hence the myopia is corrected. This treatment is mainly used for patients who are having higher astigmatism, and also some patients of myopes. Next treatment is the laser-based refractive surgery. These are the nowadays most popular and commonly used refractive procedure, which I will be explaining in detail in the further slide. The next refractive surgeries are intraocular based surgeries, like phakic lenses, means here customized a thin lens is implanted in the space between iris and crystalline lens called posterior chamber. And the next treatment is the refractive lens exchange, similar to the cataract surgery. Here the clear lens is extracted and intraocular lens is placed into the capsular bag. Or these both can be combinedly treated in few instances known as a bioptics, or also trioptics, means multi-pronged approach in some individual to treat their high refractive error. So he is the person who has done exemplary work in the field of refractive surgery, Dr. Jos Barakar. He is also known as a father of modern refractive surgery. So to begin with, the commonly and most popular refractive cornea-based surgery is the LASIK. So many people, they'll come and ask, laser ಮಾಡಿಸ್ಕೋಬಹುದಾ, laser ಮಾಡಿಸ್ಕೋಬಹುದಾ. It is a LASIK treatment, that is nothing but laser assisted in situ keratomyelitis. Means in this treatment, the main principle of this treatment involves a pre-calculated and preset excimer laser beam is used to ablate the corneal stroma. Hence, it alters the curvature of the central cornea. Hence, whatever refractive error is there, it will get corrected. In case of myope, central stromal ablation is done so that central corneal curvature becomes flattened, and hence myopia is corrected. In hypermetrope, the paracentral corneal stromal ablation is done, and this paracentral cornea becomes steepens. It will get flattened, and the central cornea becomes steepened. So the hypermetropia is corrected. So to whom these LASIK surgeries can be done? The ideal candidate for LASIK surgeries must be at least 18 years, and they should have a stable vision, means their refraction should be stable, and the cornea should be normal and clear and transparent. It should not have any pathology or like any scar from any previous injury or any like ocular surface disorder. It should not have, and their transparency should be maintained. And also the patient should have realistic expectations. There is nothing but whatever, if the patient is already having amblyopia or in some retinal pathology, so that will not be corrected with the LASIK. The main the principle of LASIK is to give the patient their spectacle vision. So whatever amblyopia, it will not be corrected. And the relative contraindications for this treatment include any autoimmune disorder or present eye infections or previous ocular injuries, especially to the cornea, and pregnant and nursing mothers in LASIK is prohibited. So what amount of power can be corrected with LASIK? That all depends on the thickness of the cornea and health of the cornea. In myopes, up to 8 to 10 diopters of power can be corrected, and in hyperopes, up to 5 diopters, and astigmatism up to plus or minus 5 diopters can be corrected depending on the thickness of the cornea. The main important the part of this surgery is the treatment planning and pre-operative evaluation. Means it begins with the complete cycloplasic refraction, means complete the refractive power of the patient, it should be evaluated, and proper slit lamp examination of the cornea and anterior segment is done, and retinal evaluation thoroughly with a dilated fundus examination, it has to be done, and any retinal pathologies, it should be treated before LASIK treatment. The main vital part of the evaluation is the corneal topography scanning. So means with this scanning, the patient is decided whether LASIK can be performed for this patient or not, or if at all LASIK can be done, what type of LASIK is suitable for this particular patient. So the corneal topography, especially nowadays, Pentacam scan is the gold standard scan for evaluation, detailed evaluation of the cornea. So I don't have any financial interest. In market, there are many LASIK machines are there, but what we are using is the Schwind Ameris 500 machine. So just to show how the machine looks, this is the surgeon's view, and this is the area where the laser beams comes. It will be used for the treatment of the patient. So procedure-wise, the LASIK procedure involves mainly two techniques, flap technique and flapless technique. The conventional flap technique involves here, the main aim is to get partial thickness, uniform and partial thickness corneal flap is made with a small hinge attached. In conventional LASIK, this is achieved with the help of a microkeratome blade with a predetermined thickness. It is passed over the cornea, and this partial thickness flap is achieved. So once this flap is created, a pre-calculated excimer laser beam is exposed to the stroma, and hence it ablates the corneal stroma, and whatever the power is patient is having, it gets corrected, and again this flap it will be reposited back without any sutures or bandages. It will, because of the vacuum pressure, it will get opposed by itself. So this was the flap technique. Next is the flapless technique, also known as a PRK LASIK, means phototherapeutic refractive keratomeliasis. Means in this technique, after removal of the epithelium, directly laser beam is exposed to the corneal stroma. So this technique used in cases like where if the patient is having a thinner cornea or steeper cornea, and also if they have a deep set of eyes where there is a risk of flap complications. So the overall advantages of LASIK include, it's a very quick procedure because it takes 4 to 5 minutes per eye, and it's almost no or very little painful procedure, and it can be done within OPD procedure. Hospital admission will not be required, and within the span of days, means within 3 to 5 days, patient get recovered and he can join back to his routine work or studies. There are many advancements in LASIK treatment, that is the bladeless LASIK. In that, first is the femto LASIK, also known as intralace LASIK. As I said, in conventional LASIK, we create a flap, partial thickness flap with the help of a microkeratome blade. But in femto LASIK, a different laser, femto laser, is used to create this flap. Because the flap what we get with the help of femto laser is, it will be in uniform thickness and with a smooth surface, because the smooth surface is it results in better clarity of vision, and like optical aberrations will be minimal. So the patient will be getting much more clearer vision. Once the flap is made with the help of femto laser, the stromal ablation, whatever the patient is having refractive error, that is corrected with the help of excimer laser. Hence, this is the femto LASIK machine. It looks like with the two different machine. Through one machine, femto laser is used to create a flap, and excimer laser machine is used to ablate the stroma. Next advancement in LASIK is the smile surgery. Means whatever conventional in femto LASIK, a large flap is made with a hinge attached. But in smile treatment, a very tiny incision is made, around 2 millimeter incision made, and with the help of a femto laser, according to the power of the patient, a small lenticule is separated and it is extracted through that tiny incision. Hence, it is known as a small incision lenticular extraction treatment or smile treatment. The overall benefit of these bladeless LASIK is the visual rehabilitation. What the patient gets is much more faster and with a very fewer complications. And also the important dry eye patient, many patients, they suffer from conventional LASIK. They have very minimal amount of dry eye symptoms following this bladeless LASIK procedure. And also because of the predictability of the flap thickness, LASIK can be done even thinner corneas also. So the next advancement in the intraocular refractive surgery is phakic IOLs, also known as ICL or IPCL, means implantable collamer lens or implantable phakic collamer lenses. Means in this treatment, a customized thin lens is placed in the space between iris and crystalline lens, known as a posterior chamber. This treatment is done whenever a patient is not suitable for the LASIK. Means a thin cornea with a very high power. Like if the patient typically soda glass kind of a patients, like if they have a very high diopter, up to 30 diopter power can be corrected with the this phakic IOL patient. Whatever the LASIK is, the limitation is up to 8 to 10 diopter, that depending on the thickness of the cornea. Here very high power can be corrected, like high myopes or high hyperops. And also if the patient is having pathologies of cornea, like scar from any previous injury or keratoconus, corneal curvature related disorder, in these cases, the refractive error of those patients can be safely treated with a phakic IOLs. So this is the picture showing the technique of implanting these phakic IOLs. This is the phakic IOL lens, very thin, flexible lens. It is implanted with a very tiny incision. It is folded and loaded into the injector, and it is placed into the posterior chamber, and the wound is closed without any sutures. So even this procedure is also very, it gives a very faster visual rehabilitation. Once after implantation, the eye looks like this. There is no marks, without even difficult for the naked eye to notice the eye lens is implanted. But with a careful slit lamp examination, a thin slit beam is seen, one from the phakic IOL lens and one from the crystalline lens. And next advancement is the clear lens exchange. Whenever if the patient is having very shallow anterior chamber depth, those patients are not suitable for these phakic lenses. In that case, their refractive error can be corrected with the clear lens exchange treatment. Means similar to the cataract surgery, a clear lens is extracted and a calculated IOL is placed into the capsular bag. And whatever power of the patient, if they having like soda glass kind of thing, very thicker glass, very high power can be corrected with these two, phakic IOL and clear lens exchange treatment. So to finally, the take home message is these all refractive surgeries are very simple, safe and faster visual rehabilitative procedure. But meticulous pre-operative workup and proper planning is vital for the success, means for the better clarity of vision they achieve, and also minimal amount of post-operative complications. And there is always a scope for combination of treatment. If the patient is having very high power, multi-pronged approach, like multiple treatment modalities can also be used initially, or if the patient is held up with an residual error after one procedure of LASIK, if, in certain cases, repeat LASIK can be done for those individuals. So with this, I conclude my talk. Thank you for patience hearing.
Thank you, sir. We had a very good lecture on cornea and diabetic retinopathy and refractive errors from the team of Ganesh Netralaya Shirsi. It's a very good team working in Shirsi. We are happy to see your hospital building also. And we all want to come to your Nayana Hall and Sir's hospital.
Welcome, madam. We can arrange a cultural show from your team.
Yeah, you can. If you call us for Yakshagana, we can come and do Yakshagana.
Sure.
Now the subject is open for discussion, and anybody wants to ask question, they can unmute yourself and you can ask question, please. As a one question from my side, like if LASIK surgery is done, is they can give the eye donation can be done or not?
Yes, ma'am. Definitely, eye donation can be done, but because after LASIK, then depending on the thickness, it may not be suitable for the optical keratoplasty, but their endothelium can be used for endothelial keratoplasty. But even in some cases, like therapeutic grafting can be used.
Okay, thank you. Our Dr. Mahesh Babu is there, our faculty, KVG faculty. I welcome you, sir. And you can, he's there in our group. Dr. Mahesh, sir.
Yes, madam.
Yes, sir.
Good evening.
Good evening, Dr. Mahesh Babu. Actually, Dr. Mahesh Babu is my, he was a classmate during my BBS.
He was in CC for some time.
Yes, yes, sir.
Yes, sir.
And there is a message, like very useful information for all general practitioners as well. Well done, team Ganesh Netralaya. And Dr. Veena madam has put, all talks were very informative, made very simple and even to common people. Congrats to whole team.
Thank you.
Thank you. Thank you.
Dr. Viswanath, sir, I want to ask
Yes,
that like if you do LASIK and then after maybe 10 years, again if there is some refractive error, can we again redo the surgery?
Yes, ma'am, definitely. There is actually the long-term complications are there with the LASIK. The two terms like regression and ectasia are there. Whatever the meticulous pre-operative workup we do, there are instances without any, we don't know, there are long-term complications like regression and ectasia happen. With that, the residual power, again, it may come back. Especially in cases like patients are having a very high power, very high myopes, especially there is a, and even hypermetropes also, there is a chances of again power coming back. If the corneal thickness permits, we can do with small amount of corrections can be repeated with the LASIK. But if at all, we have to find out why the power has come back. If the because of the ectasia the power has come back, means it the corneal curvature problem has occurred, and we have to assess the stage of that problem. Also, we know as the keratoconus, means ectasia following LASIK. We have to assess that, and it may progress in future days. So the progression of that condition, it has to be arrested before correcting the error actually with the C3R treatment. After that, we can correct with other modalities like phakic eye also. In those cases, again, LASIK can't be performed because already the cornea has become weakened, become ectatic. So in that case, it has to be stabilized first with the C3R. Then we can treat the error with intraocular procedures.
So Kudva sir
Thank you,
is joined. Sir. Our state president Kudva sir has been joined the program. Welcome, sir. If you're free, you can talk, sir. Suresh Kudva, sir.
Welcome, sir.
I don't know. He's not. Sir, are you there? Kudva, sir. Okay, I have one question, sir. Like everybody is there pledging their eyes, but as far as my knowledge goes, there is no facility for the eye to receive and to transport for the eye bank in time. So what measures you are taken in your place, sir? Shivaram, sir.
Regarding eye bank, no, what your question is, the transport.
Because most of the programs that we see, we pledge our eyes and we come and we take the certificate and come. But as far as my knowledge goes, like there is no much facility for the immediate retrieval and their collecting of eye and transportation, and we are not getting that in time. So what you have done in your place,
see,
so that we can
maintaining an eye bank in a proper way is a very big challenge, madam. It's from management side. So actually, though on record there are 25 to 30 eye banks in Karnataka, as I know, there are only 4 or 5 which are very active and doing the work, because it needs a very big teamwork of technicians, doctors, and many other social background also helpers. So what we have done is, we are 5 doctors together. We have 2 technicians who are trained. See, for harvesting an eye or taking separating eye from a cadaver, we don't need an ophthalmologist only. Any doctor or even a technician is anybody with a little skill and with the training, they can pick up and do it. Okay, it's only thing is, working in an eye bank needs a different set of mindset. Many people can't do, because every time they need to go to somebody is dead, who is dead in their house, and they have to ask all the stories of their family and then do the work and come back. It needs some service-oriented, dedicated team is necessary. That is the big problem of having such a team. But we are fortunate. We are Lions Nayana Eye Bank, where Ganesh Netralaya is a partner. Lions Club is a partner of these organizations, and Nayana Foundation manages the whole eye bank show. And right now we are doing good at present with Dr. Viswanath Ankod, who is a young, energetic refractive surgeon as a team leader.
Okay.
If anybody, including in Sulla Medical College, wants to start an eye bank, or IMA wants to start an eye bank, we are ready to provide all the inputs and how to run. It's a great service to the humanity.
Good evening, sir. Dr. Shiram, sir. Mahesh here.
Yes.
Yes, sir.
Yeah, we are very much interested, sir. We definitely need your guidance, sir. I'll come back to you, sir. And definitely need your. Actually, we had a plan here. Maybe last 3-4 months we have been discussing it, like how to go about, how to proceed and all. Definitely we'll need your guidance, sir. I'll come back to you.
Surely, anytime.
Yes, definitely, surely.
From IMA also, we had a discussion in the last meeting. Our senior member, Dr. Rangaya, was asking us to do something about eye donation, and we have to work it out like that. So that for that I asked actually how you people are doing, and so that
it's not difficult, madam. It needs a little dedication. It is not difficult.
No, if not an eye bank, you can start with the eye collection center.
Eye collection center, that's sufficient initially. To collect
until you have a full-time refractionist or refractive surgeon who can transplant the eye, you can have a eye collection center. That would be very useful initially to begin with.
Which is the active eye bank in Mangalore, madam?
No, in Mangalore, I think KMC.
KMC as well as Ennapoya has eye bank, sir.
No, many have eye bank. How much active they are, it's very important.
But when we contact them, they won't come, like within 10-20 kilometers only they are coming. More than that, they are not coming. That is the problem.
No, that's the best thing is you have an eye collection center attached with them.
Yes, sir. That can be done initially.
Yes.
Yeah.
So getting the license for the eye bank is difficult?
It is not very difficult. We need to, just like in blood bank, there are certain set of rules and regulations. It is under HOTA.
Yes, sir. We have applied for it actually. We have all the things, a specular microscope we have purchased, we have procured everything. But because of these licensing procedures, we are a little bit at a setback actually.
It's all, you need to persuade. You see, it is a government organization. We need to personally have the touch, and
yes, sir.
you need to go through your representative or MLA who can pressurize them.
Yes, sir. Yes,
come
sir.
and
Yes,
inspect and do the procedures. All
yes,
this,
sir.
it needs a back screen some activities also.
Yes, 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 sir. Yes, sir.
Yeah. I think if the question is over and we can wind up the session, I request our Secretary, Dr. Vikan sir, to give vote of thanks.
Good evening, everyone. Yeah, yes, madam.
I think Vishwanath sir can stop his screen sharing.
Yeah.
Yes, sure.
Yes.
Yeah. Good evening, everyone. So it was a very well organized, very informative talk we had today, and also nice discussion also, especially about the eye bank, which Madam and our IMA members also had many doubts about the eye banking, especially. So I thank Dr. Veena, President IMA SULLA, for organizing such a nice CME. Thank you, Madam. I thank all the speakers. Yeah, I thank all the speakers of today's discussion. Dr. Shiram Kevi, Medical Director and Senior Phaco Surgeon, Ganesh Netralaya Sirsi, for giving excellent talk. And I thank Dr. Manjunath B A, Vitreous Retina Consultant, Ganesh Netralaya Sirsi, for giving an excellent talk on diabetic eye. And I thank Dr. Viswanath Ankod, who gave a very informative talk on Odyssey and refractive surgeries. And I thank all the participants who were present for this discussion. And I thank all the supporting staff who helped in technical thing for this organizing and helping conducting this CME. And thank you one and all.
Thank you, sir. Thank you, Ravikant sir. And I thank KVG Medical College also has given a Zoom platform for us. And I thank our secretary and treasurer and Dr. Rajani and Dr. Geeta Duppa. And first of all, Manjunath sir, when we were talking just like that, and suddenly the thought came, and I thought, okay, I means we will discuss about cornea, lens, and retina at one particular day. Look, ophthalm was my passion actually. I wanted to become an ophthalmologist, and after that, I somehow missed, and I became obstetrician. Still, I'm happy with my profession, whatever. And nice to see 3 ophthalmologists today on this platform. And Shivaram sir is very active. When I was speaking to you, I was very happy to talk to you, and you are doing such a many, other than ophthalmology, you are doing such a wonderful work in Shirsi. And I want to come to Shirsi and see your performance and Nayana Sabangana. Yeah, always it is performing actions, no? So we want to visit. And you people, please come to Sulla and give the offline program once. I welcome you all to Sulla. Thank you for giving a wonderful lecture. And thank you one and all.
Thank you.
Thank you, madam.
Thank you, madam.
Thank you. Bye. Good night.